Counselor Lake, would you please lead us in the invitation?
Lord, we thank you for this day that you blessed us with. We thank you for our servicemen that are overseas fighting. Lord, we ask that you keep your hand upon each and every one that's here. Give them a safe journey home. In Jesus' name we pray. Amen.
Mary Lou Shaw. Bonnie.
Mike Dobbins.
Here.
Harley Buzzard. Joe Bird. Julia Coates. Sean Crittenden.
Bonnie.
Joe Deere.
Bonnie.
Kanan Duncan.
Bonnie.
Rex Jordan.
Here.
Darryl Legg.
Here.
Wes Snowfire.
Bonnie.
Dora Petkowski.
Here.
Mike Shambach.
Here.
Leo Smith.
Here.
Janice Taylor. Here. Victoria Swift. We have a forum.
Thank you, Shelley. Appreciate it. Now the approval of the minutes. Has everybody had an opportunity to read them?
Make a motion. Second.
Okay, motion's been made and second. All in favor, say aye. Aye. Okay, first report. George Valerie. Said that right? Valerie? My French is not good. Yeah. Morning. Good afternoon, George. How are you today?
Good, good.
How are things going with Claremore?
Going well, going well. Month of November, dental had 657 encounters. The diabetes group met with 192 patients. The lab saw 2,137 patients. Pharmacy filled just over 28,000 outpatient prescriptions. And radiology, we had 2,273 visits. Our collections are doing well. Any questions?
Anybody have any questions? I have one. Your occupancy rate for November is 19%? Was
Yes.
19%? So what's the census there at 19%?
We're usually between around 7 and 10.
7 and 10? Wow. For the whole facility, 7 and 10? 7 to 10?
For the inpatient, yes.
Yeah. Okay. Anybody else have any questions? Counselor Deere?
Mr. Ray, I did have a question. Did you get a follow-up on that when we were talking about therapy for those college
I was
kids?
told she was contacted.
She was contacted?
That's what I was told,
All right,
yes.
so that's good.
Okay.
All right, thank you.
If you find out otherwise, let me know.
Oh, I'm sure I will hear. I appreciate it. That's all I got.
How's the flu epidemic going your way?
We've had a few, not an overabundance. I had my son in last Friday in the ER, and they had 2 in there that day. So we've got a few coming through.
Our vaccine must have been effective this go around.
Yes.
Yes. Counselor Duncan?
Can you tell me any statistics on your denial versus deferral? Like who you defer and
That actually comes from the doctors, the physicians that look at those. And we only meet once a week, the review committee, and the doctors and the providers will prioritize that. And what we end up doing is we pay until we run out of money. And sometimes, depending on what type of case it is, we run out of money really quick, or sometimes we can stretch it out and get a few more cases in. But the providers prioritize that, and then the contract health ladies the office just pays until we run out.
you don't have a percentage on like your denial rate or anything like that?
We usually average around 25%, I think, over a year on approvals.
On approval?
Yes, yeah.
Thank you.
Counselor Shambach?
So 75% denied?
Well, denied and deferred, those are,
We'll explain the difference between denied and deferred.
denied is
I know what denied is, but what's deferred? Let me put it that way.
deferred is for a service that hasn't been rendered yet. You get a referral for a evaluation that hasn't been done yet, and it gets deferred. Where that term comes from was a long time ago. Apparently because if you'll read the deferred letter that comes out, It says your services have been deferred. Check back with us at the end of the year. We may get end of year money. I think we all know nobody's getting any end of year money. So I've tried to change that letter because to me it's kind of misleading. But that I was told no, and that came from a higher level than me.
You know, something that comes up quite often in my district is, and I never understood, people call in and say, hey, I've been scheduled for a surgery next Tuesday. Well, then they get a call Monday or Friday and say, hey, you've been denied. You can't have that surgery. Like 2 days before it's supposed to happen or a day before it's supposed to happen. I mean, I get those calls, and I was wondering, we're scheduling people for things, and then the day before you're saying, we can't do that. I mean, man, that blows people up. And I get blown up on it, and it's hard and I don't know what to tell them on why we would schedule something and then deny it the day before.
Well, we don't schedule them until they're approved for funding.
So how is this
Hey,
happening then?
what happens is some patients end up making their own appointment. They'll go for an evaluation and they'll go ahead and make an appointment, schedule an appointment for surgery or the next appointment without coming back and going through the referral process. So they end up making their own appointment. And what we normally do is we wait until those referrals go through and are approved, and then they come back out of committee and our office will make the appointments.
I'll just have to, I guess I need to look at the paperwork next time this happens and see the wording on that, because that's not exactly what I'm being told, but again, you don't always get the whole story, or people may not understand the process, but that's what I've been told. I was scheduled and then canceled, but I will look at the paperwork when that comes up again.
And again, I'm relating to you what's supposed to happen. Just
Sure, I understand.
Yeah.
So, but I'll get more informed on
Okay.
what the paperwork says.
if you have a question, holler at me.
I will, sir. Thank you.
Yes, Counselor.
And can
Oskowski.
you also explain the 5% program? If
That's
there's a denial and then sometimes they get referred over to this 5% program.
That's your program, not mine.
Oh, I'm sorry. I'm
That's
sorry.
Dr.
That's
Jones
correct. I'm
when he
sorry.
comes up.
Wrong person.
Counselor Buzzard?
George, do you have a patient services advocate there?
Yes,
And what's the name of
Kellen Palmer.
Kellen? Dora, we'll have, okay.
Dr.
And what do you
Jones
do
answer.
on,
Okay.
do you have people that go after Medicaid, Medicare insurance there also?
Yes, we had 4 benefit coordinators, and one left and went back to the VA, I think.
Okay.
But we still have 3. Yes,
Okay, well, my question was about the patient service.
yes, Kellen Palmer.
Kellen Palmer, okay, thank you, thank you.
George, last month you shared with us approximately how much money you have a month in contract health. Can you give that figure to us again?
It's roughly about 175,000 a week. It's easier for me to keep straight if I condense it down to as small a unit as I can.
See, I think a lot of people don't understand that there's only so much available,
Correct.
that's a problem. I want to ask you on that occupancy rate of 19% with 7 to 10, do you reroute your staff or something?
Did we what?
I mean, when you only have 7 to 10 patients in-house, inpatient, what happens with your full-time staff?
They're still there.
They're still there.
They don't work on a PRN as needed basis. They're there. I try to utilize them somewhere else if I can.
Yeah, I understand that. Okay, anybody have any other questions? Counselor Crittenden?
Yeah, the deferment paperwork.
Yes, sir.
Does that have anything to do with donation, or is that a different entity that makes that rule?
Difference?
They won't let me change the letter.
Right, because the deferment, what I got from you was actually a denial, right?
They are. In practical terms, yes.
So is that a Cherokee Nation thing that won't let you do it?
No, it's an agency.
Thank you.
You know, we were talking about those inpatients, and what percentage are those IHS employees? Are they all IHS? We got some that are travel there at Claremore?
No, they're all IHS.
Are they all
Well,
IHS?
I take it back. Behavioral health, the programs you guys, that the nation has taken over, behavioral health, WIC, public health nursing, and then the Cherokee Nation side of contract health, those are all nation employees.
Okay. All right. So majority are IHS then?
Yes.
Okay.
Yes, sir.
Thank you, Madam Chair.
Anybody else with any questions? George, you have a safe trip going home.
Thank you.
Okay, and Dr. Steve Jones. Good afternoon, Dr. Jones.
Good afternoon. All right. Let me give you some updates before we get to questions. I wanted to call attention to a couple of things on the report that you have. First one being the left without being seen rate in the emergency department and urgent care. We normally run about 4.9, and if you'll notice on this report, it's 1.9. So that's a pretty significant drop in left without being seen. I want to make sure we
Do you attribute that to any
That.
policies or any changes or anything?
We're just working a little harder to make sure that we are staffed correctly and make sure we're decreasing our wait times as much as possible. We've asked the director of the urgent care and the ER to come up with some outside-the-box thinking of how we can be a little more efficient. So we're looking at some stage planning on how we can implement some new strategies to getting our patients through that process a little quicker.
Excellent.
On 2 pages in, you'll see the provider recruitment down 3.8% on vacancy rate. We roll on over to the revenue year-to-date. That's a projection, of course, because this is based on a 12-month projection after the first month, but we're ahead of where we were last year. So we're projecting that we'll beat our numbers from the year before. You go on over to services delivered by quarter, and everybody's trending up. And with the exception of Jay, they trend down just a little bit, but on the majority, everybody trended up. And then the last part of your report is what you asked for last time, is top diagnosis by clinic. So it'll give you an idea of what kind of things we're facing out there. And if you see the encounter for immunization, I'm sure that's a lot of flu clinics and what goes along with that falls in that category. So you'll see that at the top because this is what we concentrate on this time of year. So you'll see that at the top of each one. So you can kind of check down to the next diagnosis, and that'll give you a little better idea of what is currently out there. Okay. And then I want to give you some updates on some other information, and then I'll have Dr. Montgomery speak here in just a minute to a letter that you guys all got from Counselor Shaw on some stuff that we updated her on. NSU PA school has been something that's kind of been on our radar. Dr. Dobbins has asked me several times about it, so I just wanted to update our information on that, is that they go through their final accreditation on February 3rd and 4th. We have some people sitting on their board, but we aren't affiliated directly with them, but we will have their students, if they get accredited, in our system working, doing rotations. So we're keeping a close eye on how that's going. Like I said, their final accreditation is the 3rd and 4th. Update on OSU. OSU has accepted 42 of their 50 students of their first class already. So they're filling up very fast. Dr. Dobbins asked me what the percentage of Native American are in that first class. I don't have those numbers. I just know that there's 42 of the 50 seats are filled already. So I'm sure we'll be getting that information shortly. Stillwell, I'll give you an update on Stillwell. They've started preparing the building for demolition. We've got a side-by-side vehicle out there to help patients get from the bottom of the parking lot to the top so they're not having to walk up that hill. We've got that on site, and we've got people manning that currently. We're still dealing with the parking issues and knowing for sure how many people are going to have to park off-site. But they are functioning out of the temporary buildings, and everything seems to be going going well as can be expected. So I've been over twice, and both times the staff was very flexible, and they were working very hard to make sure it's minimal disturbance to the patients. So, okay. Harley, you asked me about the TVs last time, and Jay, we've got a group coming in to assess Jay and Oshaleta. Those two places that we did not have the audiovisual TVs for the patients in the waiting areas. I don't know why those two clinics didn't get that process, but we're looking at what the cost would be associated with getting that done. Okay. I don't have any new information other than we've got a group going out and going to give us an assessment on how much it's going to cost. All right. We're developing our healthcare teams. I think I've talked about that before, more centered around the providers. One of the things that we recognized we needed were medical assistants, and that's something that we haven't used a lot in our system before. Diane Kelly, to her credit, has worked with ICTC, and they're offering a class on certified medical assistants that they will be starting soon, and graduating some to help us fill that need. So I want to give her credit for being proactive and getting that started. That's going to help us on down the line with filling those positions with local talent. We've got a minor remodel going on over in Clinic in the Woods, which is going to house our public health and WIC administration. We should have those final groups and our diabetes administration moving over onto campus by the end, about the start of March to the end of March, somewhere in the month of March. So that'll get all of our health team all on one campus, which will be the first time we've ever had that. So we're looking forward to that. And then in the new facility, we're working on getting surgery clinic opened up. That's the next phase that opens, and we're looking at the end of February to have that clinic up and operating. So it'll be outpatient surgery only. We'll still do inpatient surgery in the hospital, but outpatient surgery should move over into the new clinic, and we should be able to take some of the pressure off of our OR suites in the hospital. So. And the only other thing I would like to update you on is have Dr. Montgomery talk a little bit about the Tramadol shortage that we're facing. So.
Hello, Dr. Montgomery.
Hello, everyone. It may surprise you to know that common medications that are used every day across the country ebb and flow in their availability. For a short period of time, I worked as a hospice physician, caring for people at the end of life with severe pain. During that time when I took care of hospice patients, we ran out of morphine. Many patients were allergic to other pain medications. It created a tremendous challenge to care for those patients. I used that to illustrate the situation we found ourselves in the last few days. I was notified last week that a common pain medication that is used by our patients called Tramadol is in extremely short supply. The details of why it's in short supply are not clear, but it originates with the manufacturer. And again, the availability of that medication is going to be a critical issue in the next several days, in the next few weeks, for our patients who take Tramadol. Tramadol is an opiate pain medication similar in strength to codeine, Tylenol number 3, not nearly though as strong as hydrocodone or morphine or oxycodone. But patients that take it on a daily basis regularly, if they go without it, are at risk for experiencing withdrawal symptoms. So it's best that they not run out of that medication. So I have sent out a message to all of our providers, and we'll be notifying the pain specialists that care for our patients of our situation, so that when our patients go to refill their medication, our providers will use their judgment. There's no, here, substitute this, substitute that. It will require our providers using their judgment whether to refill that or use an alternative medication to substitute for Tramadol during a period where we run out of the medication. Patients who do not take Tramadol on a regular basis, and many just use it as needed 2 or 3 times a week because they're not taking it regularly, will not experience any withdrawal symptoms. But those that do take it on a regular basis could experience withdrawal symptoms. and they should be mild, but you can't predict the severity of someone's withdrawal symptoms. And it's probably best that they have a substitute medication prescribed for them for a short period of time, hoping that the manufacturer's problem with providing the medication to us will be resolved in a short period of time. So again, we've notified all our providers. We're compiling a list of the pain medication doctors, the pain specialists see our patients, and notifying them of our dilemma so that when patients contact them, being informed that we can't get the medication through our pharmacy, that they're going to need an alternative medication. And by the way, the supply, this is not just Cherokee Nation, it's just for not-for-profit, it's across the country and involves for-profit entities also. Any questions? Did I explain that okay?
Yes,
I
Councilor
just got a
Gill.
question. Since there is a shortage on Tramadol, will that affect other people with their insurances that are on insurance, not at the clinic, but will they make some kind of rule if it's not covered since they're out of Tramadol that it will be covered? The whatever the other medicine they prefer?
Yeah, I anticipate that and don't have an answer for you yet. We need to come up with a potential solution for that. I see what you're saying though, yes. But I don't have a solution for that yet.
Okay.
Councilor Dobbins?
Yes, Doctor, do we have providers that specialize in pain management?
We do not have any board-certified pain specialists on our staff.
So we just try to equip our primary care providers the best they can for pain management?
Yes. And providers are all different. Some are comfortable prescribing pain medications, some are not.
Right.
And again, providers through our system vary in their prescribing of pain medication.
Councilor Lake?
Yeah. So instead of an opiate, is there any way that you could, especially for patients that do have insurance, could provide prescription Marinol? It's a THC derivative from cannabis, but it's absolutely 100% legal and it's sold in pharmacies. It's not something that you get at a dispensary, but it's a safe, non-addictive alternative to pain meds.
It would not substitute though for an opiate.
Well, it'd be a lot safer than an opiate.
It would not substitute for an opiate to transition directly from Tramadol to Marinol.
Right, but if we could set up something where we give them an option from the get-go, instead of this opiate, would you rather have this Marinol?
Right.
You know, is that something that we would be interested in doing? Because
We have not prescribed Marinol in the past because, again, we receive federal funding, and that's viewed a little differently. We don't have it on formulary currently also.
Right.
So I would have to look at that very carefully and consider that as an alternate
if
treatment.
you would, that would be great.
Okay, Councilor Shambaugh?
I would assume that regulations on drugs in different countries may not be up to the standards of ours or may be different. You know, you always hear about cheaper drugs up north, Canada, things like that. Have we ever thought about going into that market and looking to maybe sustain this? They may not be having the shortages that we have because maybe they don't use them as much as our country does. But are there standards similar to ours where we could look in a place like that maybe to subsidize when things are low?
It's something we could look into.
That might be, I mean, I know I hear things are a lot cheaper there, and it may be something that we could save money and it could benefit us too.
We could look into it.
Thank you.
Councilor Taylor?
For patients that are on daily Tramadol, will that require a physician's visit in order to switch them over? Oh, wow.
Likely will, yes. If you're prescribing a new medication according to the Oklahoma law, you would need to have probably a face-to-face encounter for that.
So are we being proactive and contacting those patients that we have, or is it going to be at the end of their prescription, you got to get in line?
The prescriptions will run out at different times, so
Right.
again, we've notified the providers and asked them to make themselves available to see those patients as needed.
That's all I have.
Councilor Crittenden?
Yes. Kind of what Council Lady Taylor there. Have we notified the patients that will be receiving some bad news potentially?
We have not done that yet.
Is it a Cherokee Nation policy, kind of how we're dealing with it? I'd say our officials got together and say, here's how we're gonna deal with the. Okay, so
Yes.
did I hear you right? Each provider will, it'll be up to them whether they get some more Tramadol or not, right?
They won't be able to get Tramadol if we run out. It will be up to them to decide which medication to prescribe in place of Tramadol.
Up to that.
Yes.
Whether no medicine you can do without it a while, or maybe another option. That's kind of what
I
it is.
encourage the providers to prescribe a short-term alternative, hoping that we'll get Tramadol back in stock relatively
Right,
soon.
right, everybody's hoping that, and it's a nationwide thing, but that's kind of what it boils down to our folks is, you're gonna get another drug for a while, or you're gonna get nothing for a while.
I don't think that will be the case. I don't think anyone wants people to experience withdrawal symptoms.
Wants, right? Right.
Yeah, so I've encouraged the providers to prescribe an alternative medication.
So we shouldn't be getting calls saying, my provider didn't prescribe me anything.
I hope you don't, because I think we've tried to make the providers aware of the need to accommodate the patients during this special, special time.
That's all we can do.
Do our best.
Thank you.
Counselor No Fire.
Did Tramadol send over maybe a list of medication that they probably thought would be more conducive to transition them to for a short period of time, or is that just all going to be off our judgment? I mean, you guys probably got a lot of research with the different kinds of pain management drugs too, but I don't know if they had maybe sent over a list of drugs that they recommend that might be able to use as a substitute.
The manufacturer has not done that. As I said, I contacted a pain specialist. I've talked to a couple of them, getting their advice about this because, again, that's their area of expertise.
Right.
And I've worded it as carefully as I can. They've recommended providers consider prescribing an alternative medication.
Good, great. All right, appreciate it, Doctor.
Yeah.
Appreciate it.
Anyone else with any questions on this?
Just a comment. Dr. Montgomery, thank you for this update. The initial thinking was that it was just affecting Cherokee Nation. But the way you explained it, if this is nationwide, then we just take the, appropriate steps and use the expertise of you guys and recommend back to us what we need to do if there's something from the legislative branch here. But we appreciate the update.
And if I may say it another way, this is a manufacture and distribution problem totally out of control of Cherokee Nation. Totally out of control of Cherokee Nation.
Thank you.
May I share with council that an opioid, it's not like they're going to have to come back. They would have to come back for a refill anyway of the Tramadol. That is not something that they can prescribe where you can just get it refilled automatically any longer. That law changed, I guess, several months ago. So they would have to go back to their provider anyway when it's time for a refill. So it's not like it's this extra trip it's a trip they would have had to make regardless.
Okay.
But I applaud Dr. Jones and Dr. Montgomery in getting this message out to us before this happens, because it's going to happen in the next few days that these calls are probably going to start. And I thank you so much for making us aware of this, so we know and are available at least to respond in an intelligent way.
Sure.
Thank you so much for that. Any other questions here regarding this? Yes?
If I could, just real quickly, I want to brag on them and let you know on behalf of Chief Hoskin and Deputy Chief Warner, it's one of the ways we want to make sure we communicate with the council on what's going on. And so earlier this month, the health team notified us that we were having challenges trying to meet the demands of the urgent care and the ER right after Christmas. And so we sent a message out to you to let you know. And so in the same vein of that, they're being very proactive in communication and trying to let you guys know if there are challenges in front of us and what's going on, so that you're aware of in case you do get phone calls from your constituents. So I do want to brag on these guys for making sure that you guys are effectively communicated with on the changes that are coming about. So.
Yes, Councilor Crittenden.
Yes, just a real quick follow-up. I agree. I appreciate those heads up. Like Mary was saying, and Todd, we appreciate those heads up. And I missed so do we have any plans to find out who's going to be affected by this patient-wise and contact them personally?
We've asked the Director of Pharmacy to come up with a list of the patients, but again, it's very hard to know when exactly a person's medication is going to run out because people use them in varying amounts.
Right.
They don't always just use them as prescribed.
Will we have a list of, could
We
you
will
come
try
up
to-
with a list of people on it, not when they're going to run out, but this person's on Tramadol, And let's say it's 5 years before they need some more. But we wouldn't have to worry about when their prescription's coming due. It's just who's on it. This is potentially gonna happen to you. And that would be a little bit to add to our heads up that we've already got.
Now, we wouldn't be able to share it with you. It's
No.
But
The
we
patient.
share it with the providers so that they would, it would be my plan, so that they know when to potentially anticipate a call from the patient. Does that make sense?
Well, and this may be impossible, but there's no way to be proactive with the patient themselves.
Again, it's very hard to know how they've been using it and whether they're actually going to run out at a specified time, because people use these medications in varying quantities during the course of a prescription. You know what I'm trying to say?
I don't think we're getting each other's question. Can a list be generated? Let's say my neck of the woods, Wilma P. Mankiller, to the people who can see it, not for me, but who's going to be contacting these patients, who's going to be contacting me, and in turn contacting you. These dudes right here take Tramadol sometimes. And is there a way to get that? You may be affected in the near future, you may not be.
Let me look at the best strategy for dealing with that, if you would, please. Okay?
Thank you. And you know, there's strategies to look at a whole lot of things that we've done well and we could do better. So, yes, that's a fair deal. But I think sooner that patient knows, because that's going to be a shocker, you know, to some of them if they don't get around to.
I'm hopeful that it will not be a shock, other than that they're going to have to be just potentially changed to an alternative medication for a short period of time. That's the ideal solution.
Right, and I think letting them know that as soon as possible, and you probably agree, that's where I was going with that.
So in most cases, like Counselor Shaw had said, they're going to be calling for the refill when it's time for the refill anyway. It's not something that they get to send in and get an automatic refill of.
So they're going to be
So they're going to be
calling.
contacting anyway. And at that contact point is when the alternative medications could be suggested. So all we're asking is if someone sees this and they contact you and say, I'm getting ready to not have this or whatever, that you direct them to their provider so their provider can make the decision on what's best for them, because their needs may be this drug, or maybe this drug, or maybe this one. We don't need to determine that as a policy.
Bottom line
the
is,
provider needs to determine that.
they're going to have to go see their
And
provider.
they would anyway.
Right.
They would anyway.
Thank you.
Counselor Coates?
Thank you. I have a question. This is just a medical question to try and understand something a little bit better. Are there degrees of dependency depending on what kind of medication a person may be on for pain? Would that be a fair statement, that certain things are more likely to lead to greater dependency than others, things that are more difficult to withdraw from than others might be, et cetera? Is that?
It's a tough question to answer. Again, not being a pain specialist, I don't see the term degrees of dependency used very often. I think it's more just, is that person using an opiate on a regular basis? And are they therefore they're likely dependent on it if they use it regularly, and could likely experience withdrawal symptoms if they go without the medication.
Okay. The reason I'm thinking this is because and again, totally out of ignorance, of any of this, I don't know if there's a possibility that alternative medications that might be prescribed for hopefully a temporary period in the interim would potentially lead to a situation of a person having an even more difficult time withdrawing from those and returning to Tramadol. I don't know if I'm stating it very well, but if there are things that might be more difficult to withdraw from in terms of getting back to Tramadol when it becomes available again.
The email that I've sent to the providers described the relative equal potency of codeine to Tramadol and the higher degree of potency of hydrocodone and oxycodone and morphine. There, we look at pain medications compared to morphine and tramadol is 0.1 equivalent to morphine at a similar dose. To give you some idea, it's quite a bit, it's much less strong
Yeah.
than morphine.
Right.
And so in theory, I think you're right. And that's why I said in my email, the likelihood of withdrawal symptoms would be relatively mild for most patients that take tramadol on a regular basis compared to someone who took morphine on a regular basis. Is that,
This is, no, absolutely. And so this is something that physicians will deal with routinely, is these sort of comparative values and taking that into
Yes.
account. Okay.
yes. Good
Thank
question,
you.
very good question.
Counselor Austin?
Now, I think a lot of what we're talking may end up being theory, because I'm sure the manufacturer's working feverishly trying to resolve the issue themselves. And so by the time many of these people's prescriptions are ready to come due, the problem could be resolved. The supply chain could be resolved.
I am hopeful, yes, that it could be, yes.
Let's hope. Let's hope.
Yes.
Because that would make 2/3 of what we're talking about here theoretical anyway, because it would be
Yes.
resolved by the time it was needed. Of course, it's great the fact that that we think in terms of being prepared for things, but hopefully most of our patients will never experience it, because the problem will be resolved by the time it happens.
Right.
Counselor Shambaugh?
Just real quick, I might have missed it, or I didn't read it, but what kind of pain are we talking about? Level of pain are we talking about that this drug treats? I mean, what is, you know what I mean? There's different levels of pain.
The recommendation for the use of tramadol is for mild to moderate pain, excluding the word severe.
So we're talking, could be any numerous kind of ailments could bring this type of pain on, just not a particular kind. And
Yes. And you will
Like
talk to
such
patients who will tell you, they've tried this and this and this, and tramadol is what works.
yeah, but,
It's that way.
thank you.
Anyone else?
I have one for Dr. Jones. The schedule for optometry, I know you and I had this discussion, a lot of our students are in for the holidays, and optometry was closed at Northeastern for, 2 or 3 weeks. Is that something that you think you can get resolved?
Yeah, the new contracts that started January 1st now require Northeastern to observe our holidays instead of their own holidays. So if it's a day when we would normally be open but they would be closed, they're required to staff the clinics.
Sure.
And if it's our holiday, then they're not going to be staffing, because we have run into that before, where it's a day where we observed a holiday but they did not, and they wanted us to have the clinics open for them. So now we have that paralleling and running together concurrently. So that shouldn't happen again.
Thank you, that'll be very accommodating.
Yeah, and that started
Okay.
January 1st. So the old contract ended December 31st, new contract started January 1st.
Second, the volunteers at our new clinic,
Mhm.
are we going to train other people to take on that task, or do we feel like our people are becoming acquainted with our new facility?
We're still going to work with that group to have volunteers in place for wayfinding. It's been a big hit, and we've had a lot of positive feedback. And so if we can continue to work with Diane Kelly's group, again, giving her credit, that's the group that's helped us to have those people trained and on site to walk patients to their appointments, help them find a wheelchair if they need a wheelchair, or a motorized wheelchair. We have those available if a patient is unable to walk a long distance. So it's been a big success.
Yes.
Counselor Smith has helped us with
Sure.
that, and I'm sure he can speak to that too. It's been a
I thought it was a great
rewarding
deal.
thing
I
for
enjoyed it.
everybody.
Yeah, it was good.
Our plan is to continue.
Okay, all right, thank you, Madam Chair.
Counselor No Fire?
Just had a quick comment. I know with the holidays, I had a lot of people asking for help and needs, and I appreciate Dr. Jones. I see Mr. Carey back there and Dr. Montgomery. You guys just really help out. I think I've sent I think both New Year's Eve and Christmas Eve, I had emails that I sent you guys, and I really appreciate you guys looking out for us, and it really helps me out. It really helps our patients and our citizens out. So thank you guys a lot. Appreciate
You're welcome.
Okay. Counselor Smith?
Was OSU pleased with the 42 of 50 on the medical school?
That came out in another discussion. Dr. Nolan, who is working with us on getting our residency program up and running, and so I don't have any of the details to that, but I'm sure it is. I mean, at this point in time, we're in January, and we're talking about the time of year when applications are being reviewed. For them to have 42 already confirmed accepted, that's a pretty high number at this point.
How many you think this ballpark will apply for that?
I don't know that number for sure. They'll have 50 in their inaugural class. So.
Counselor Buzzard.
Dr. Jones, last month we talked about the release of electronic records. Have you had any more discussion about that?
I haven't. That's in the AG's office, and
okay.
And that's not something that, as when they work out all those details, they'll let us know what we need to do.
The other question I had is, you mentioned medical assistants a while ago. What kind of a job description are those going to be doing? What is a medical assistant?
Certified medical assistant is there to aid the physician and do whatever the physician can delegate to them. It's a little different than a nurse, than what the nursing board allows. There's two different positions, certified and non-certified, and we're wanting certified medical assistants in our care team.
So it's not a PA.
No, it's not a PA. Yeah, it would be on the same level as an LPN, and that status as an LPN.
Okay.
But it
that
would
was
be
my next question.
Yeah,
What
but
kind
it
of
would
training?
be directly working with the physician. So, medical assistant directly working with the physician on the care team. There are certain things that you can delegate to them, and certain things you can delegate to other people on the team. So the idea is to get everything built around the provider to reduce the amount of busy work the provider has to do, so we can facilitate more efficiency and triage patients on what level of care they need. Some will require care all the way up to physicians. Some just may need a mid-level to take a look. Some may just need to see a nurse that day. So we need to have that ability to be flexible so that we can facilitate the needs of the patients and not be sitting and waiting all day long to see a doc when maybe that's not what they need to do.
That concerns me a little bit, but I guess it's worth seeing how it works. The first thing I'm going to hear is, I can't see a doctor, but I think it's worth a shot to see it, because I know right now our RNs are tied up doing what they're doing and not doing really nurses' work to me, but I know what they're doing. So that concerns me a little bit about how many of those we're going to get and what level of care they're going to be giving to our patients. So I'm willing to wait and see how it works.
We'll definitely be working with our physicians to work through this process and make sure we're meeting all their needs and make sure we're meeting our patients' needs. Obviously, if a patient requests to see a doctor, then we're going to honor those requests.
Sure.
But if you're coming in for a sinus infection, maybe you don't need to see the physician to get moved through. So.
And I think there's certain things that will work. So anyway, I'll just wait and see how it works out. Thank you. Thank you, Madam Chair.
Sure. Chief of Staff.
If I might, and I'm sorry I walked in on the tail end of that conversation, but I did want to share a personal experience from my wife's perspective. She's a nurse practitioner as well, a mid-level provider, and she's worked in our healthcare system previously at Hastings, at Stillwell, Salina, Muskogee's. I'm going to forget the other 2 or 3 clinics she's worked out of. But most of her patients that she dealt with often called her doctor, and she had to correct them multiple times. And there's quite a bit of bond and flexibility that both PAs and nurse practitioners have as a care team to try and help the physicians so that they can treat the ones that are. Just want to share that piece.
As to the e-signature, I can speak from the AG's office. We did receive an email. I checked with Elizabeth, who historically has worked in health, also with our AG's department. And it was our decision that we felt it best for them to still require the patient to sign off allowing the medical records, that an e-signature, there is a lot more room for false requests, and it does not take a sufficient amount of time or hardship on our patients to just have to sign it and send that back instead of an e-signature. So that was the decision that the AG's office felt was the safest conclusion.
I guess the point that I was trying to bring about that is if you have an electronic signature, then you could send those records electronically over there to them, and you don't have to make a bunch of copies and stuff like that, which would save time. And just reading from the email that the person sent us, that almost every other institution does it electronically anymore. And my point is trying to speed up the services for people that need those records sent over there for disability. But, you know, that's the reason I was asking about, you know, what our position was on the thing.
And we can still send electronically. We just need the release of information signed by the patient. Once they sign that release of information, we can still send it electronically. We don't have to make copies and make hard copies. We can still send electronically.
We just have to verify that truly was the patient requesting it, just, you know, with HIPAA and all of those things. Again, the AG's office just wanted to be on the safe side to make sure. Sometimes family might request it and the patient actually doesn't want it. So they just sign the patient's name. There's just a lot more room for a false signature going through. But if the patient signs it, then everything else, like you said, can be sent electronic. We just felt like we are truly abiding by what that patient wishes.
So the reason they're not going to accept electronic signature is because of other things that could happen, is that what you're saying?
Well, I think that's how you analyze any situation is how certain are we this signature is the patient's? How certain are we that the law is least likely to be violated? So that was part of the analysis when discussing it with the AG's office. Because again, I received the question, went back as far as historically, what have we done in the past? What is our position currently? Is there anything that's changed? And then that's, like I said, the advice that I have received.
And that goes with even here within the Cherokee Nation. I know we do a lot of things electronically. Signatures, so why aren't we concerned about that?
So there's a difference between a copy of a signature and a typed signature, and that's what he's providing. It's not a signature, a copy of a signature. It is a typewritten signature. And so there's no way to verify it's not the patient's signature, it's just typed on the form. And under HIPAA, for us to be able to accept that, what he sent was saying that other states have adopted that law that allows e-signatures. And that's not the same as what, we don't have that law that says e-signatures, if that's
Are you
something.
talking Oklahoma?
No, in Cherokee Nation.
Cherokee Nation. It sounds to me like we're a little behind the ball to me.
I mean, if that's the direction tribal council or anyone else wants to go, that's something to discuss, of the ability to verify that type of signature when it's just typed on a form. And that's the difficulty when you're doing that versus a copy of a signature, which we allow those all the time. So if someone sends us a copy of an authorization, they could be in Kansas. They sign that authorization, they send it to us. We accept those, accept a copy of the signature. The problem is with the ones that he's trying to send, it's just typed on a form. And so there is no signature, it's just a typed name on a form.
Okay. Thank you.
Anybody else with any questions? Okay. Dr. Jones, when I was reviewing the top diagnoses by clinics, I just thought this was interesting that Muskogee had more diagnoses than Hastings in the top 5. I thought that was interesting. And if you look, encounter for the first one, encounter for immunization, 1,045 at Hastings, and yet Muskogee has 1,657. Do we need to look at long-term plans at the possibility of enlarging Muskogee?
Well, this came before we've opened. I mean, this is from December, so we were in the transition of services and things like that of that nature. So you're going to see a little decrease in services because we ramped down to make the move, then ramped back up. So you're going to see that dip at Hastings because of that move of services.
Okay, now that I can understand. But I'm sitting there thinking, oh my gosh, there's so many more diagnoses out of Muskogee.
And they were actually ramped down to less than 50% or less, just to facilitate the move from one facility to the other.
That makes sense. I want to share with you that there is some people who feel we're having a problem with our wheelchair scales, that evidently they're in some type of a cubicle and there must be a desk or something that's in there or something, but it's preventing the purpose of weighing someone in wheelchairs.
So, and we're talking about Tahlequah?
In Tahlequah, Hastings, yeah.
Okay.
Could you check on that for me? They
Visit
said
with
there's
me on
is there 20 to 40 scales in that facility?
That I couldn't tell you.
Yeah, but anyway, they wanted me to know that that was a problem.
Okay.
And another on refills, again, refills, the patients are having to go to the clinic to get their refills. They're not being able to call them in and then drive through and pick them up. Is there a reason for that?
In some cases, they have to see a physician for their
Right, I
refill.
understand.
In some cases, there's a consultation that has to happen. In some cases, they can deny the consultation. So it's just a matter of what that prescription is and what the rules and regulations are on that prescription. Because I do know there are a lot of people that are using the drive-through that that don't require that trip in. But there are some that do, and there are some medications that you can do it once or twice, and then it requires that trip in. So there are limitations on medications and what the regulations are on those.
Okay, but some people can actually call in
Absolutely.
and then just drive through and get the refill.
Absolutely.
Okay, they don't have to go in and wait, okay? And patient counseling, again, that's come back up. If they have been on a drug and the prescription's been a year or whatever, do they have to undergo patient counseling again for the same medication?
That's something that we're working through on what is required and what is recommended. There are some medications that do require consultation and some that do not, but we're working through that to try to figure out what the most efficient process is for a pharmacy.
Okay, very
'Cause in
good.
the past, they've required it on, I think, all medications, so we are working through that process.
Very good. Well, I appreciate, again, you all keeping us informed ahead of the storm, so to speak, and thank you very much for that. Does anyone else have any other questions? Okay, thank you so much. Announcements. I do want you all to know that there was a committee that met last Thursday to explore the viability of forming a medical insurance company for indigenous Oklahomans. And this possibility will be explored in the coming months. If you all have any questions, please talk to me after this meeting. And then the next meeting is tentatively scheduled for Monday, February the 10th at 1 p.m. Thank you so much. Adjourned. Motion and second. Okay, thanks.